Hi, thanks for joining us. My name is Jack Rychick, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought on your part. We'd love to hear from you and to get your questions and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started. Hi, we're going to have our first session today on an interesting topic, atrioventricular canal defect, elements in the balance. This will be presented by a colleague and a great friend, Merrill Cohen. Merrill is the professor of pediatrics in the Department of Pediatrics at the Perelman School of Medicine, University of Pennsylvania. She's currently the director of the fellowship training program. And Merrill, we've known each other for more than 25 years. We're not going to say how many more years than 25, but we'll just sort of establish that
it is hard to
as
believe.
a fact. I know this particular topic of atrioventricular canal defect is something of interest to you. You've explored this in a number of different ways. But tell me what first got you interested in this. And my recollection is that I was perhaps a junior attending early on, and you may have been a fellow.
I was.
And what happened after that?
Well, we would have our surgical conference as we usually do, and a patient with unbalanced AV canal came up for conference, and this was our post-operative conference and had had quite a bad outcome. And one of the surgeons in the audience turned around and looked at the bunch of us fellows back there. I must have been the closest one to him, and he pointed at me and said, "You're going to figure this out." And I think after conference, you came up to me and said, "I'm going to help you figure this out." And so it became my fellowship research project.
Yeah, that's fantastic. I mean, that's I think a story that many of us who have been grown up to be successful in academic medicine can probably retell, where there was a particular patient or a situation that sort of prompted a query that then led to an investigation.
Yes, that's exactly how it happened.
And here we are 25 years later, and we're going to hear this fantastic talk from you. My suspicion is that I'm not sure we have answered that surgeon's question just yet fully, but we definitely have learned a lot about this particular condition. So let's go ahead with your talk. Again, atrioventricular canal defect, elements of balance.
Thank you so much, Jack. And as you said, I have been trying to investigate this problem for a very long time, over a quarter of a century, which is shocking. But I do think that there's still a long way to go with regard to that question. And so just to start us off, as we know in the normal heart, there's for the AV valves, there's a mitral and tricuspid annulus, and the aorta sits wedged between them, as you see there. In common AV canal, you have a common AV valve annulus, which leads to the aorta sort of the outflow tract elongating, and the aorta further away because of this annulus. And you can see how you might have disproportionate amount of blood flow to each of the ventricles as a result of that, such as if you see in this, as you see in this figure. You can have the balanced form of AV canal where the valve is distributed equally to both ventricles. As you see here, here's the ventricular septum. Whereas with unbalanced AV canal, the valve is directed more towards one ventricle than the other, and the other side is smaller than normal with a smaller mural leaflet. So when the AV valve is aligned more over one ventricle than the other, this occurs in about 10% of cases. In the right dominant form, you can see that both atria tend to empty into the right ventricle, and in the left dominant form, both atria tend to empty into the left ventricle. It's usually associated with hypoplasia of the contralateral ventricle, and this follows the flow model of growth. Unbalance to the right is much more common than unbalance to the left for reasons that are unclear, actually. But we know, in the interest of time, we're not really going to talk about the left dominant form of this lesion. There's a very high morbidity and mortality associated with unbalanced AV canal, thus the curiosity in trying to fix this problem, and much more morbidity in this lesion than in the balanced form. So why is that? The surgical strategy, there are two options. You can do a two-ventricle repair in this case, but as we're sort of alluding to, it's difficult to predict the severity of imbalance. And I'll come back often to this problem, which is the subaortic region, which is quite vulnerable in even balanced AV canal defect. But in unbalanced, it's even more of a concern. And you can have AV valve tissue in the way, and overall, the outflow tract can be very small. The left-sided AV valve is also small in this situation when you try to divide the valve. And if you try to close the cleft, the apposition where the superior and inferior bridging leaflets come together, which we typically do in the balanced form of the disease when we do a two-ventricle repair, you're likely to wind up with significant AV valve regurgitation. And if we are guessing wrong and the left ventricle is inadequate, you can get high filling pressures, diastolic dysfunction, and this results in back pressure to the right side of the heart and can put these patients at risk for pulmonary hypertension. So in the process of trying to septate the atrial and ventricular septum, you can run into all of these problems. If you decide that the patient's going to go down the single ventricle pathway, this is a higher risk lesion in almost any outcome study you look at compared to hypoplastic left heart syndrome. And we certainly know that a number of the patients who have unbalanced AV canal have Down syndrome, and single ventricle strategy is not ideal in this cohort because of the risk of pulmonary hypertension. And we also know that in all outcome studies of single ventricle, AV valve regurgitation is quite bad. It can worsen after surgery. And it's more likely to require valve intervention than those patients with this more straightforward form of hypoplastic left heart syndrome. So why haven't we figured this out yet? The preoperative physiology is really quite different than the postoperative physiology, and we have to make a dichotomous decision for disease that has a variable spectrum. There are more variables to consider: the two holes in the heart, the left ventricular outflow tract, and the AV valve, and we don't really know how those are going to behave after we try to do a repair. An intervention may leave the patient with residual hemodynamic abnormalities and may result in new pathophysiology, some of which may have nothing to do with the decision you made. We alluded to AV valve regurgitation and stenosis, but if you go down the single ventricle pathway, for example, you can get shunt thrombosis as a cause of morbidity and mortality that has essentially nothing to do with the intracardiac anatomy. And so this is what we're left with. We're left with a heart that looks like this, with a big hole in the center and a common annulus. And we're asking the surgeon to make these planes in space such that the left ventricle will be adequate to perform its duties of providing systemic output. So what then defines unbalance? There really are not universal clinical or imaging criteria. We also know that in unbalanced AV canal, or in balanced AV canal, the right ventricle is larger than the left ventricle because of the atrial level shunt. We also know that you can have pretty significant unbalance at the valve level without significant ventricular hypoplasia. That makes it a bit tricky. And there really haven't been so many publications about this particular lesion in contrast to things like hypoplastic left heart syndrome or transposition or tetralogy. So as Jack was alluding to, we sought to try to answer this question. As my fellows project, I looked at echo variables of unbalanced AV canal to try to determine if we could predict who would survive two-ventricle repair. And we noticed that in the left anterior oblique view that you got a really nice en face view of the AV valve, as you see here. And you could then divide that valve at the ventricular septum into a portion into each side. And we made a ratio of the right AV valve over the left AV valve to try to help us determine balance. And it turned out that an AV valve index, this index, it's actually left AV valve over right AV valve, my apologies, less than 0.67 was what we determined as unbalanced. We also noted in this study of a relatively small cohort of patients in a single center study was that if you had a large VSD, this was a risk factor for poor outcome for biventricular repair. We weren't really quite certain why that was, but we surmised that the ventricle, the VSD might be supporting the output, and that once you closed that defect, the patient had low cardiac output. Many years later, I joined forces with the Congenital Heart Surgeon Society to try to perform a multi-institutional study, again, to answer this question about whether the AV valve index really determines unbalance. So we wanted to validate if this index was a discriminator of balanced and unbalanced forms of the disease. We wanted to correlate the index with surgical strategy and other echo features of LV hypoplasia and obtain pilot data for a CHSS prospective inception cohort study. We modified the index to look at the left AV valve area divided by the total AV valve area, and we made a predetermined discrimination that an AV valve index less than 0.4, less than or equal to 0.4 was right dominant form, greater than or equal to 0.6 was left dominant form, and between 0.4 and 0.6 we determined was balanced AV canal. And then we decided to apply this to what happened in the surgical strategy of these patients. This is a frequency plot that depicts the probability of a given surgical strategy as predicted by AVV index. It's important to be aware that these surgical decisions were not based on these measurements, but it was a nice sized cohort, 305 patients. The red lines are single ventricle repair. The blue are two ventricle repair. There are a few patients who had pulmonary artery banding. You can see that the majority of patients with an AVVI less than 0.2 had single ventricle repair. And the majority of patients between 0.4 and 0.6 had a biventricular repair. But what you can also see is that surgical strategies employed were quite heterogeneous in the range between 0.2 and 0.4, with a relatively high mortality as demonstrated by the dots on the lines here. When you looked at it another way, this is a prediction nomogram for repair type based on AVVI. Again, blue is the biventricular repair, and red is the univentricular repair. Vertical axis represents the proportion of patients in each of the categories, and the horizontal was the AVVI. This was in 341 patients. And you can see, again, that if you have an AVVI of 0.2, the patients are as likely to have undergone a two ventricle repair as a single ventricle repair. But by the time you got to an AVVI of 0.4, 90% of the patients had undergone a biventricular repair. So AVVI clearly helps us predict what surgical strategy is employed. We also looked at those patients who had an AVVI less than 0.4 to correlate it to other markers of LV hypoplasia. And you can see that it correlates very significantly with all of those markers. But AVVI, not surprisingly, is not enough to make these determinations. It turns out unbalance, the AV valve may not correlate with ventricular volumes. And we also have to address the fact that there is abnormal geometry of the left ventricle, in particular of the left ventricular outflow tract and the ventricular septum, that are not accounted for with this one measurement. Our previous work had shown that VSD size could impact outcome, and this does not help us predict whether the AV valve will be incompetent after surgery. And we know that these patients primarily have ASD physiology early in life, leading to usually a very high QP because of poor LV compliance, potentially low cardiac output, and pulmonary hypertension. So we decided that since this was not enough, we wanted to look at other aspects of left ventricular inflow. And here's just sort of a picture to describe some subtle differences that you might see in these patients. So you may have the type of unbalanced AV canal where there is flow getting into the left ventricle even though there's unbalance. But you may also have this type where all of the flow is directed entirely to the right ventricle and essentially no flow is getting into the left ventricle. And just by the AV valve index, you can't make that determination because you're not looking at where the leaflets go. And so here's what that looks like on an apical four-chamber view. Here's the AV valve annulus. And you can see essentially that this AV valve leaflet is entirely covering the left ventricular inflow. And you can also see this in this apical 4 moving clip where essentially none of the flow is getting into the left ventricle. So this is clearly a big problem and is not predicted by AVVI. So how is the blood getting out to the body? It tends to get out through the ventricular septal defect, which shunts right to left in systole. And so you can understand then if you are to try to do a complete repair in this situation and you essentially have no inflow and you close the ability of blood to get through the left ventricle and out the aorta, you will not have a good outcome. So this is really a marker of inadequate left ventricular output. So along with my colleague Anita Zwast, we looked a number of years ago to try to give a sense from echocardiography of how much blood is actually getting into the left ventricle. We measured the annulus divided by what we could see of the color flow actually getting into the ventricle. And this inflow index helped predict survival in these patients, such that if you had an index less than 0.5, none of those patients survived. With the Congenital Heart Surgeon Society, we probed further. And in this paper, we decided to identify factors that characterized unbalanced AV canal and its impact on outcome by making a number of anatomic and physiologic measurements, and then performing a cluster analysis to assess which features distinguish groups of patients. We sort of just put everything out there to see what would come out. We then did a discriminant function analysis to determine the most important variables. And the thing that really came out in this analysis was this RV to LV inflow angle, which you see here. You see on the top of the screen a sort of acute angle here and a more shallow angle here. And it really, the cluster analysis distributed the patients essentially into 3 groups. But when you looked at if it affected outcome, you could see that between groups 1 and groups 2 and 3, there was clearly a distinction. The patients in groups 1 were much more likely to have a biventricular repair and to survive it and have low mortality. But you could see that it really didn't help us distinguish between the groups in group 2 and group 3. They essentially had the same outcome. So this is helpful, not perfect. Others in other institutions have also looked for these variables by echocardiography to help them make this determination. This was a nice paper that came out of Argentina a number of years ago where they used the AVVI and this indexed VSD, which is actually very similar to the angle that I just showed you, to help clarify surgical decision making. And they noted, again, that smaller VSDs are more likely to survive biventricular repair, similar to what we had found in our original paper in 1996. We also have to try to figure out if we can predict LV volumes after we septate the heart in these patients. And this is quite challenging in unbalanced AV canal because there's such a large VSD. And so there was this theory that the LV is squashed before the procedure, but that you have potential for it to be much larger when you septate the heart. And you can measure LV volumes in these patients with CMR. It seems to be more accurate at predicting LV volumes than echocardiography. And so this is one of the tools in our armament to help us in this decision-making process. And finally, I just want to touch upon this mural leaflet concept. In patients who have unbalance of the left AV valve, it is associated with a smaller mural leaflet such that the area of apposition of the valve is primarily at the cleft where the superior and inferior bridging leaflets come together. You can see this on this 2-dimensional image as well. And so the cleft becomes the primary coaptation site and might put these patients at risk for significant left AV valve regurgitation after surgery. But it turned out that sometimes you investigate something and you find what you don't expect. And so with one of our recent cardiology fellow graduates, Deb Ho, we tried to look at the left valve morphology and its association with late AV valve regurgitation after AV canal defect. It turned out, of course, that in unbalanced AV canal, the mural leaflet was indeed smaller and more acute based on the various measurements that we made, which you can see on the right side of your screen. But there was the increased odds ratio of late AV valve regurgitation was not actually related to a smaller leaflet. It was related to a larger mural leaflet, which just goes to show you that you go looking for something and sometimes you get an answer you don't expect at all. I'm going to leave you with two cases of unbalanced AV canal and sort of the approach we had taken. This was a newborn with mildly unbalanced, based on AVVI, unbalanced AV canal to the right with a very large primum ASD, clinically important common AV valve regurgitation before surgery, and this is an important feature. Small but unobstructed left ventricular outflow tract, mildly hypoplastic arch that did not need repair and was not ductal dependent. The duct was closed. And what you see here is in our measurements, the left ventricular inflow index was reasonable. The RV to LV angle was also reasonable. So all of our markers that we use seem to be reasonable to point this patient in the direction of a two-ventricle repair. But there were two features that were quite worrisome in this patient. The patient had significant AV valve regurgitation before surgery, and also the AV valve annulus was quite small, and the left ventricular outflow tract was quite small as well. And so what were we going to do? The MRI to look at LV volumes and physiology demonstrated a very high QP to QS of 7:1. The QS was very, very low, and again, this is because of the poor LV compliance. So the shunt was primarily at the atrial level. We decided that the patient was too high risk to discharge home because of the low cardiac output, and surgery was performed at 2 weeks of life with closure of the primum ASD, partial valvuloplasty of both sides of the valve when they tried to septate, and a pulmonary artery band, leaving the VSD open so that it could augment cardiac output in this situation. This is some of the postoperative imaging in that patient. You see that despite the valvuloplasty, there's severe AV valve regurgitation, and even though there's no outflow tract obstruction of the left ventricular outflow, it's quite small. But this was the most worrisome sign of all. You can see that the Doppler pattern in the aorta shows a very short ejection time, suggesting that the cardiac output was very low. And unfortunately, the patient did not survive the surgery. Second case is a 3-month-old with Down syndrome who was referred to us from another country. Absence of the right ventricular, right superior vena cava, so had an LSVC as the blood flow getting back to the heart. Again, unbalanced AV canal by our index, large ASD and VSD, this time minimal AV valve regurgitation and no arch obstruction. But some of the things were still worrisome in this patient. The AVVI was about 0.38, so in that zone of heterogeneity based on our CHSS data, and the LV inflow index was very marginal in this patient. And so what to do? This patient had Down syndrome, so we really were trying to avoid single ventricle strategy. There was a significant atrial level shunt like in the other patient, and there were really borderline measures of inflow, as I just showed you. But there was no arch obstruction, and the left ventricular outflow tract again was small, but not obstructed. And so we did the partial ASD closure and the pulmonary artery band. And in this patient, you can see that the left ventricle filled, the inflow looked adequate, there was not AV valve regurgitation on the left side. And if you looked at the ejection time based on the cardiac, as a surrogate of cardiac output, it looked completely normal. And this patient ultimately was septated and did fine. So in conclusion, we talk about the elements of balance. The AVVI is a valid diagnostic echo tool that identifies patients with unbalanced AV canal. We have other tools in our armament, the inflow index, the RV-LV inflow angle, the indexed VSD that we've learned about from Argentina. These are all helpful surrogate markers of LV adequacy, but there are other factors that are not accounted for in these morphometric measurements, including VSD size and the direction of flow, the left ventricular outflow tract, and the risk of AV valve regurgitation. Additional imaging, such as CMR, may be helpful to support decision-making in these very complex patients. And a stage 2 ventricle repair may be a good alternative in certain patient populations, so doing it in stages rather than all at once. Thank you very much for your time.
Meryl, that was a fantastic lecture, very enjoyable, and really a very nice description of the entire landscape of how we have developed a means to characterize atrial ventricular valve defects. Let me see if we can distill this to sort of a practical recommendation or suggestion. If you get a call today and there's a newborn in a cardiac ICU with the suspicion of an unbalanced AV canal, what are you going to tell the operators, the intensivists, your cardiology fellows, to what they should be looking for to make the best judgment as to how to proceed forward?
I do think that the index sort of helps us discriminate, who really has an unbalanced canal and who doesn't. But then I hope that I've emphasized in the talk that what is getting into the left ventricle is really essential in this situation, and you can really be fooled. And I think, in our earlier work, we didn't really recognize or appreciate that sometimes even with what appears to be mild unbalance at the level of the valve, blood is not being directed towards the left ventricle. In other forms of LV hypoplasia, where there's a mitral valve, we know what's getting is getting in. So this is a fairly unique group of patients because you have a common valve that can really be essentially directed only towards one ventricle. And I think that these other measures that we've come up with help us to determine if enough blood is adequately getting into the left ventricle. It doesn't always predict it accurately, but it does help us to build a case whether we can certainly succeed in 2 ventricle repair, which is what we hope to do in most patients in this situation. What I think it doesn't account for is there are so many factors in these patients. I didn't even get into, if they're ductal dependent or not, and arch and such. The thing about these issues is that we can always fix the arch, and we can even ultimately fix the LV outflow tract in most of these patients, but we can't fix the inflow always.
Yeah.
And so that's really sort of the key to most forms of LV hypoplasia. The one thing that I think is different in unbalanced AV, the 2 things that are different are the LV outflow tract, because it's quite small and vulnerable to obstruction later, and may just not be adequate for the patient to get cardiac output. And often in association with that is you'll see a lot of AV valve regurgitation because the blood can't get out to the body. And so those are the kinds of patients who, you do septation and you've made a mistake when you have a lot of AV valve regurgitation afterwards.
Well, one of the things that I sort of think about when I hear or look at an unbalanced AV canal is there is sort of the notion of LV hypoplasia versus the notion of LV inadequacy. And
Right.
there's a distinction there because in many of these circumstances, as you've shown, there's a reasonable sized left ventricle.
Correct.
And it can be quite deceptive. But yet that left side may be highly inadequate because of the degree of unbalance and, as you've shown, inequity in inflow into that pumping chamber. We can do things about the outflow tracts. We can do things about the arch. But if the inflow is inadequate, then that ventricle is inadequate no matter what the size of the left ventricular cavity.
And I think what we found sort of by happenstance in our first study, that VSD size was a factor, is really that. Really, it's sort of a marker that the LV is inadequate, right? If you have right to left shunting at the ventricular level, then you know that the inflow into the ventricle is inadequate. And then when you try to close that hole, even if the LV looks alluringly okay, you will wind up in significant trouble in those situations.
Yep. So you touched upon it just briefly here, but so what, let's say you go down a particular pathway, what then defines failure for making a decision as to whether one should transition in some way or perhaps try and ameliorate the situation that you have in some manner with a two-ventricle system?
Well, usually the surgeon will just tell us that we're wrong, so it makes it very easy for us to know. But if they don't, I think that what we tend to do is our bias is that if we've made a decision, we want to stick with that decision. And so if we've made a decision for a two-ventricle repair in a situation, then we really want to try to keep it if we can. But what you'll see in a patient who has failed is that they won't be able to extubate. So that's sort of the first, signal that something is quite wrong. They will have high filling pressures. They will have pulmonary hypertension. And all of those things will increase their morbidity and potentially mortality. And some of those things may take some time to recover, but they may never recover. And so some of them may be irreversible. I think AV valve regurgitation after the surgery is also just a hallmark of potential failure because yes, it could be that the valve itself is a problem, but it also might be a marker that the left ventricular outflow tract is a problem.
Mm-hmm. Yeah. Let me shift the discussion just for a moment and talk about our profession and particularly your role in developing the next generation of professionals in pediatric cardiac care. You're the current director of our fellowship training program, and to a degree sort of set the stage and the message for the elements of what should go into our future pediatric cardiologists. So what things do you look for? What do you look for in potential candidates for our profession? And once we have those ideal candidates, what do you want to focus in on to imbue them with as they move forward into their careers?
Well, it's a number of factors, but I think it's very important to have passion for what you do. I can tell you after being a pediatric cardiologist for over 25 years that I still love what I do, and so you want to instill that in your trainees and hope that they have those same feelings too, because it's a long, sustained career potentially, and it can be hard, and we take care of some very sick patients, and outcomes are not always perfect, and so you have to be able to sustain that by your passion for what you do. So I look for people who really just seem so excited by this field, and one of the things that I think is an absolute deal breaker for me is being honest. I always talk to my trainees and applicants about the fact that you must be honest in everything you do in medicine, because if you're not, it completely breaks trust. And I would find that a very hard thing to come back from if somebody lied to me in a clinical situation. And so I'd much rather that somebody tell me they don't know the answer to something, or they forgot to do something, or whatever that is. That is a much better answer. I may still be not happy with you, but then actually just not telling me the truth. And it's a character flaw, and that kind of character flaw pervades and continues. And so I think that I can't abide by trainees who do that.
Critically important.
Yeah, I mean, it's not really a problem in our trainees, but it's certainly something I instill in them. I think that they need to know that they can speak up, and that when they think something's important, they can take a stand about that. So there needs to be exchange and intense curiosity, not just for their own subspecialty area that they may be striving towards, but all aspects of pediatric cardiology. I do think that the best subspecialists in our field are the ones who have a very broad knowledge of pediatric cardiology in general. I think if you hone into one area, that you're going to miss other things. And so I think those are extremely important. They have to have empathy for both families and their situations, trying to see things from their side, particularly when things get difficult, and also for their colleagues. it's very important to me that there's a team, esprit de corps amongst fellows. You're going through a very difficult transition in pediatric cardiology training, and to me, that it makes it much easier if you can rely on the people that you're going through it with.
Let me shift gears just for a brief moment as well, somewhat related to what you've been talking about in terms of who you're looking for as the ideal candidate. But I think it's pretty clear that there is in medicine in general, and if one takes perhaps an objective look at pediatric cardiology, that there is gender inequity within the field itself. Interesting that the founders of the field themselves were, in fact, women who sort of set the stage and the foundation for basic understandings. But what goes through your mind as you're trying to, again, develop the next set of professionals in our field itself? And in particular, have there been any specific role models, women role models, that you've emulated during your career?
Yeah, so I'll start with the role models. When I was a pediatric, when I was actually a medical student, I did a rotation at Boston Children's Hospital in pediatric cardiology just by happenstance. I just needed something to do, and I went up there to do that rotation, not knowing anything about the field. And I was on the step-down unit, and there was this petite, dark-haired woman who was on service named Jane Newberger. And she, what I noticed immediately was she was surrounded by all these men who were sort of strutting around with their stuff. And she was this quiet woman who, like Ruth Bader Ginsburg, would speak softly but with such authority. And I noticed quickly that all the men in the room, when she would speak, would listen intently to what she said. And really,
that still happens today, by the way.
Absolutely, and really valued. But she was a lot younger then. Really valued her opinion about patient care and decision making. And it was very clear to me, like, who was sort of running things around there. So I remember in the back of my head thinking, wow, that's a person to aspire to be like. Sort of put it in my collective. And then when I was a resident in New York at Mount Sinai, there was a extraordinarily competent clinical cardiologist. She's not famous like Jane Newberger. Her name is Rika Arnon. And she was this powerhouse of energy. And I would just follow her along like a worshiping fan. And she would sort of run up the stairs and do an exercise test. Then she would go see a patient and diagnose tetralogy of Fallot. And then I remember vividly going from an exercise test with her up to the NICU to do a bedside balloon atrial septostomy. And she would just run from place to place, extremely competent in her knowledge and full of energy and passion for the field. And I knew that I wanted to be just like her. And of course, Vicki Vetter, who was a division chief, a very young female division chief. There still remain only 6 female division chiefs in the country of over 50 programs. But she was one of the first and really helped pioneer that, and sort of seeing her do that in the setting of having her own children growing up, and she sort of negotiated and figured out how to make that happen for herself, and I always really admired that about her too. So those are just some of the handful. So I think women in general, as you said, the field was started by 2 pioneering women, Maud Abbott and Helen Taussig, and what you can get from them is that often they were disparaged and they were told their ideas were dumb or that they couldn't do something. And they figured out to have sort of an inner confidence in themselves, knowing what they needed to do. And they had a lot of grit and resilience. And even when they were told no, they would figure out another way. And I think a lot of the women leaders in our field and in general are sort of apt to do that. I think they're still at a disadvantage, and these are some of the tools we use to make it right for ourselves.
Great. So let's finish with this. We share many interests, and one in particular is the business that we're in, of imaging and echocardiography. We've grown up together in the field. what makes a premier echocardiographer in your mind? I've kind of thought about that, and I have my own sort of thoughts on it, and I'm happy to share that. But I want to sort of get your view on what are the skill sets that are necessary to really be a good echocardiographer?
So I've also thought about this, and I think, as I alluded to earlier, having sort of a good knowledge of all of general cardiology, I think really helps. But in particular, I think a really good echocardiographer has to have a really good understanding of cardiac anatomy. And that was sort of, training at CHOP and having the opportunity to work with Paul Weinberg in particular to learn all the variations of disease and spectrums. And also with Alvin Chin in our echo lab, who really sort of always brought it back to anatomy. So we have always been a very anatomy-driven lab. And I think functional assessment of the heart is very important. But I do think a really clear-cut understanding of anatomy and all of the spectrum of disease that we can see is essential to being a good echocardiographer. And it also requires an ability to sort of put together two-dimensional imaging, in a three-dimensional way in your head. And not everybody has that ability to do that. So that's sort of a skill that you sort of learn that you have or don't have. And also just to be able to recognize, like sort of pattern recognition. I think at this point in my career, you could put a clip up and I pretty much know what's going on in a very short period of time. And the reason is just because I've looked at things hundreds and hundreds and thousands of times to be able to recognize that. To recognize normal and variants of normal, and importantly to recognize variants of abnormal.
Yeah. I
don't know what you think.
Totally agree with all of those. A couple of additional things. So to reinforce the concept, pattern recognition, critically important. Some people are visual, some people are more verbal in their neuronal networking and neuronal connections. And I think we talked about this a little bit earlier. Sometimes you can look at a first-year fellow and you can tell that the basics are there to build upon to develop echocardiography skills. And for some people, it's just not there.
Right.
Doesn't mean that they can't still do a competent echo.
They could always do cath.
They could do other things. They could do, and there's plenty of other things to do in our field. But there is something that is unique about developing your skills in relation to pattern recognition, and then being able to say, this makes me think of diagnosis X, Y, or Z. Here's the other thing, and I think experienced echocardiographers like ourselves, I'll put ourselves into that category. We almost would we kind of name that tune. I can name that tune in 3 or 5 or 7 notes. Sure, after 2 or 3 clips, I look at something and I could say, I think I know what it is, and I try not to share that. But as I was doing that recently with a fetal echo, it struck me that if you self-analyze what you're doing, it is you're looking at something, you're forming a preliminary diagnosis, and then you're either accepting it or denying it based on the next set of images.
Yeah.
So there has to be an element of self-doubt when you look at something to say, now wait a minute, I see something, it suggests a certain interpretation, it suggests a particular diagnosis, but I'm not sure because I still need to see something else in another plane, in another angle, and look at an orthogonal view, et cetera, to then firm up and confirm that diagnosis. And then once you get multiple images, you get that thing and it clicks in your brain, you say, that's what that is. Right.
I also think, similarly, a preconceived notion or preconceived bias is pretty much every time I've made a mistake, and I've made plenty of mistakes.
We all have, yes.
Yes, but almost always it's because I had a preconceived bias in that situation and I tried to shove my decision-making into that preconceived bias rather than doing what you're just saying where you have to sort of step back and say, hey, maybe I'm not right about this. So when I see myself going in that direction, I try to step back and say, okay, let me look at this again. And honestly, one of the great joys of our field is that we can get other eyes to look at things with us and sort of come to consensus together rather than being out on your own. And being in an academic environment allows that wonderful opportunity of engagement.
Yeah. Well, Meryl, this has been great. It's been fantastic chatting with you over the last couple of minutes. An awesome talk on AV canal defects. And I want to take this opportunity for thanking everybody for joining us. And I'm sure there are a lot of important lessons that folks have learned, both from the content and science of what you presented, as well as some of your professional experiences. And thank you all for your attention and for listening to this fantastic talk and life lessons and life advice. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.